One of the things that I've observed over the years in my private practice days, go all the way back to 1982, is that government has, has taken over about 50% of the healthcare system. That's pre-Obamacare. And in fact, now CMS, which controls Medicare, more or less controls the entire system from the standpoint of whatever decisions are made for Medicare eventually makes its way to TRICARE and to Medicaid, and then eventually to private insurance itself. The whole concept and idea that physicians, healthcare providers can no longer decide what they can charge patients. That's up to somebody else. That came from Medicare. And Medicaid then eventually made its way throughout the system. So for instance, people say to me, well, Dr. Fleming, why don't you publish your rates? You know, be transparent. And my answer is, well, I have no idea what my charges are because I don't control them. It's the people who pay them, not the patient, but the insurance company, Medicare, Medicaid. And there may be thousands of different pay rates, sometimes for the same actual activity or the same service that we provide. So what good is it to put a price board or a menu board up there and disclose to you something that I myself have difficulty finding? I just get what I get. That's it. And of course, that's a problem for you trying to comparison shop. Who's the best doctor? Who has the best value for service? Well, you have no way of doing that because I can't disclose it to you. And you can't find out that information, so we have a problem. So that's pre-Obamacare. Now, it's true that we have about approximately 30 million Americans who for whatever reason, are uncovered when it comes to health insurance. About half of those choose to not be covered. Mainly young, healthy people that calculate that the money is better spent for beer. Okay? To be blunt, and to be honest with you, if you look at it from their perspective, it's a pretty good bet that if you're 25 years old and you're perfectly healthy, that what is the chance you're going to need a lot of health care and a lot of insurance? So therefore, you take the risk not to be covered. And then when you get older, of course, you want to be covered. But by then, you may have accumulated one or two disorders, and now you have a pre-existing illness, which is a problem. Now, there are appropriate ways to deal with that, and we can get into that. But the point is that Obamacare tries to solve all these problems. It tries to force people to take insurance. It tries to force employers to provide insurance. It tries to create a top-down standard all the way from Washington as to what should be contained in an insurance policy. It transfers income from one class of people to another class of people. And at the same time, it does nothing to lower the cost of health care. In fact, it creates plenty of incentives to actually drive up the cost of health care and overutilization. And at the same time, creates subsidies, which is going to make you feel like you're getting something cheaper. But again, remember the old discussion about the used car salesman. He increases the price and then gives you a discount. You end up paying what the original price was in the beginning. Well, that's the way Obamacare is designed. Not purposefully, but that's where we end up with it. Because if you don't have the cost control mechanisms created by market forces, then the outcome is going to be higher and higher cost. Then there's only one mechanism that I'm aware of in Obamacare that is designed to cut costs, and that is a rationed board. It's called the Independent Payment Advisory Board. Now, there was a lot of controversy at first. Gee, is it true that this is a rationed board? Is it true that this is a death panel? Well, I'll let you decide. Sarah Palin was told it was the lie of the year and so forth. But the truth is, there does exist a panel of 15 individuals that will be selected by the president, not necessarily doctors or even healthcare workers, who will have the power as to what services will be provided, to whom they'll be provided, what they're going to cost, what they're going to be reimbursed. And it's going to be based on quality. But that quality is also matched against budget. And when the budget falls short, which it will, then we'll have to make cuts. And that means less services. Not necessarily saying that you won't get that service, or not necessarily saying that you can't get that service, but if there's no doctors who get adequately paid to provide that service, you don't have access to care, then you're not going to get it. Okay? And there are other countries who've done this, and the population accepts it. That's a value that the people in Canada and in Great Britain have already accepted, although they have an escape valve. For candidates coming to the U.S., for Canada, they have a very robust private system that's built up so that they can escape to that, but only if they have enough money. If you don't have enough money, you're stuck in the old system. And if you're told that you have cancer, and yes, there are treatments that could potentially cure your cancer, but they don't see that there's a cost-value relationship that's adequate, then you don't get treatment. And as a result, you go home and die. Have a very robust hospice system. Their survival rates when it comes to cancer, particularly the big ones like prostate and breast, their survival rates are much lower than ours because we.
Those ways we go back. Do you have a feel for how that's going to?
Well, we've brought it up for repeal 40 times in one form or another, and we pass it every time in the House because it's controlled by Republicans. In the Senate, they never take it up. So that, I think, it pretty much tells you that until we have a majority in the Senate, and even then, we would have to have a president willing to sign it. One of the things that we're hoping to do is if not defund it, is to delay it. We can delay the taxes, we can delay the implementation year after year until finally the administration realizes, because again, each week goes by and we find out something's been delayed for a year. Why? Because the data hub is not set up, the exchanges are not set up. I mean, there's so much of this after 3.5 years they hadn't figured out yet. And so I would think they would want to delay it, and we certainly want to delay it, until either it's perfected or improved, or until we just decide to scrap the whole thing and start over. So I think our first position, my position, is to defund it, because we can't repeal it. And the way to approach that, of course, is to say to the President that we will send you a continuing resolution to fund government, but we have to defund this bill, this law. That's number one. Number two is, failing that, is to seek to delay it a year. And to be honest with you, I think that the President, Harry Reid, and others secretly would love to do that. I mean, again, remember, the President's already taken about 10 actions to delay. This thing just isn't ready for prime time.
How can you do that? That's something that's really, doesn't seem constitutional. It's a law. How can he choose to step forward and say, okay, this part I don't want implemented, but I do want this part implemented? Because if you take out the business, it's not fair for the individual parts of the forward.
Yeah.
I'm very frustrated with that.
I agree with you. The way the law was written was basically in skeleton form, and it was left to the regulating agencies to write in the rest. So another way to look at this bill, this law, is that it's an endless blank check. It doesn't have to be funded each year. It's an entitlement program, which means if people qualify, they show up, they get the money. Okay? And a blank check as far as the other ones. Number one. Number two is the Secretary of HHS, who is civilians, is given at least 1,100 individual important decision points in the bill that she can decide on. And basically, that's the President. Because the President, she'll do whatever the President tells her to do.
So she has this authority.
She has massive authority. She has massive, it's almost a kingly authority. And so the point is that this law was deliberately written with the idea that before it would get implemented, that they would lose the supermajority that they held, and that it wouldn't depend on funding, it wouldn't depend on further laws passed. Now, having said that, I agree with you tremendously, not just with Obamacare, but other things. I feel like the President has way overstepped his boundaries, his legal boundaries, in a lot of things. But this bill is basically written in such a way that it says, Mr. President, Secretary of Civilians, do whatever the heck you want with our healthcare system, 160 of our economy. It's written. And you may have seen the stack of rules which are not all created regulations. Like this picture, now, I wish I had a blow-up of it where I'm standing next to it. It's 7.5 feet tall. And it's thousands, tens of thousands of pages of regulations. You see, the original bill is only about 2,700 pages, which is a giant bill. But what it says is, whatever the Secretary of HHS says is what we do. And that's the way it's written, unfortunately. Yes?
I have two questions. I have about 1,000, but that would be funny. I really, I don't understand that the House has a responsibility back up to collect revenue or voting revenue. So this was considered a tax by John Roberts.
Yeah.
How are y'all left out of saying, no, we didn't pass, we didn't vote on a bill, we didn't vote on taxes to the American people, and that's what John Roberts said, it was called a fine or
Yeah.
a penalty when Justice Roberts did that. And with that in mind, why hasn't the House done something to make that argument? And also, why can't y'all be funded? Nobody was for it in the House, no public voted for it, nobody read it. Anyway, why are there so few Republican representatives that are standing with my belief that it was to be funded and saying no?
Well, let me explain how funding works in Washington, because you have to understand this to really know why it is the way it is. There's two kinds of funding in budgets in Washington. There's discretionary. Discretionary is the budgetary dollars that we can increase and decrease from year to year. We decide that, that's in our power. That all begins in the House. Spending and taxing authority. It's called the origination clause of the Constitution. That sits with the House. But there's another part of the budget called mandatory spending. The reason why it's called mandatory is because if someone qualifies for it under the rules that are created, the regulations that are created, they get it, no questions asked. And it doesn't matter how much it costs. We just have to write the checks. A good example of that is Medicare. If you're under Medicare and your bills come back $100,000, we have to pay it. We don't budget that. There's no line item that says, Mrs. Smith, your Medicare is going to be $100,000 this year. There's no such thing. It's an open-ended checkbook. You are entitled to whatever you're entitled to under law. So the only way you can change the spending authority is to reform the underlying structure of mandatory spending. It's also known as entitlements. What's in there? Medicaid, health care for the poor,